Welcome everybody to this week's Power Hour, which is offered to you by the Kanoff Institute for Physician Leadership and North Carolina Medical Society Foundation. My name is Danielle Snyder, and with me today I have Franklin Walker, who, as always, our eminent moderator for the Power Hours. Today's session actually marks our 15th week of Power Hours, very exciting. So as a reminder, the Power Hour came about as a way to provide a forum where we could focus on conversation and collaboration, and above all, community during some very challenging times. Since our start back on April 4th, we have covered a wide variety of important topics in healthcare, and today's topic is the LGBTQ community and access to healthcare. Before I hand it over to Franklin, who will introduce our guests for today, I do want to remind you, that we do invite you to engage with our guests, ask questions, and share comments. You're welcome to unmute yourself or put your question in the chat box, and we will be monitoring that throughout. We do ask for anyone who's just listening in, please stay muted. We are recording the session, and this will be made available to you the next week and can be accessed through the KIPL landing page where all our previous sessions are as well. So with that, thank you all for joining today, and without any further ado, I'll hand it over to Franklin.
Thanks, Danielle, and thanks everybody for joining us today. And we want to get right to it. So what I'd like to do is just introduce our guests today. First of all, we have Holly Lewis, MD, PhD. Holly is a resident physician at Duke Surgery. She is a study author of Duke Gender and Health and Wellness during COVID-19. Her pronouns are she, her, and hers. Dane Whicker, PhD, is in the Psychiatry and Behavioral Health Sciences Division of Duke Health. He is the Director of Gender and Sexual Diversity Initiatives at Duke Health. His pronouns are he, him, and his. We also have Dr. Kelley, who also has an MPH. She is an endocrinologist in the Department of Medicine at Duke Health. She's the co-director of Duke Adult Gender Medicine Clinic. Her pronouns are she, her, and hers. And finally, we have Dr. Jugta Kahai, who is a pediatrician. She is the pediatric medical director of Columbus Regional Health System, and her pronouns are she, her, and hers. So to get us started, we just want to go through and ask each one of our guests to tell us a little bit about their practice. So let's begin with Dr. Kelley. Would you just tell us a little bit about your practice, please?
Sure, thanks. So my name is Kelley. I work for Duke Endocrinology. I started the Adult Gender Medicine Clinic in January of 2018, so it's been about 2.5 years now. This is a combined effort with endocrinology and family medicine at Duke. So my partner is Tiffany Kovis with family medicine. We prescribe hormone therapy, and we refer patients for other gender affirming therapies.
Thank you. Dane, could you give us a little bit about your practice, please, sir?
Absolutely. So I'm Dane Whicker, and I'm a clinical psychologist by training. And so I started actually with the pediatric gender care clinic at Duke when I arrived about 5 years ago. And so I work with families and kiddos, and on that end of the spectrum, on getting started on puberty suppression, if that's something that they're interested in, and hormone replacement therapy. And so I'll do the evals for that. And I also do the behavioral. And then when Dr. Kelley and Kovis started the Adult Gender Medicine Clinic, I joined them as well. And so I've always worked with transgender adults as well, but it was fantastic to have their program. So we work together as a team, and I do the pre-surgical behavioral health assessments for the insurance companies like to have. So.
Super, thank you, sir. Dr. Lewis, how about you?
Hi, so I'm Dr. Holly Lewis. I'm an MD, PhD. resident physician at Duke Surgery. So that means I'm in my second year of clinical surgical training at Duke. I spent last year here as well. I'm in general surgery, which means I'm getting kind of an approach to all parts of the body: arms, legs, belly, groin, pelvis, all over the place. Currently working in breast surgery. My interests are in, my research interests are in transplantation immunology, the reconstruction of abdominal catastrophe syndromes, reconstructive surgery in general. I have a few publications in basic science where I work on stem cell therapy for immune-mediated diseases. And I have also been doing some work with the plastic surgery division while at Duke. I've done a couple of cases with Dr. Kristen Rizak, who is one of our plastic and reconstructive surgeons here. I am interested in health disparity research. Some of my past work has been focused on sickle cell disease in African Americans in Atlanta, where I came from. And I'm currently working on a research project with a lot of great support from some of those same aforementioned folks, looking at challenges accessing healthcare during the COVID pandemic, particularly for our transgender patients. I work at Duke. I'm also a Duke Health patient, and a lot in the transgender clinic. And a lot of our patients have had barriers getting healthcare during COVID, whether that's general surgery, cancer surgeries. We've had a lot of barriers, all of us have, obviously, during the pandemic. And my research interest at present is looking at that from kind of a systems-based practice perspective and understanding how we can better serve our patients in the North Carolina community.
Super, thank you. And finally, Dr. Kahai, tell us a little bit about your practice, please.
Hello, I'm a pediatrician. I serve as Pediatric Medical Director for the Columbus Healthcare Region. And I have a wide array of responsibilities. So what I love most about my job is that I'm in a very rural, underserved area. And as Holly said, I really believe in improving and trying to eliminate health disparities and other barriers to healthcare, whatever they may be. So that's a big passion for me. I'm very passionate about children who are have lesser opportunities, such as foster care children and children who've been abused. And I've been on as a child medical examiner for the state for about 20 years. I'm deeply interested in mental health and try to provide that to the best degree I can every day. And I provide care services at the hospital here and family birthing services. So when we were children, every morning our father used to wake us up and take us to a mirror and have us each say an affirming sentence. And you know, I didn't realize at that time it was nothing to do with gender affirmation. It was just an affirmation in general that would make us feel better. But it's strange how the world comes around in a full circle, and then you start realizing how important those small things were and how much they taught you. And so I try and give back to my patients, and I try and learn from my patients, and that's really why I'm here. And I'm so proud to be here with the rest of this distinguished panel, and I really appreciate it. Thank you.
Super. Thanks for joining us. Okay, so let's talk a little bit about the terminology that's probably going to be germane to our discussion today. And so I want you guys to define or tell us what LGBTQ plus means, and then also get into the difference between transgender and transsexual. So Dane, would you start us off with that, please?
Sure. So there's a lot of acronyms that are going around. I think I use LGBTQ plus, and that stands for lesbian, gay, bisexual, transgender, and then we also have intersex, allies, asexual, and so it can kind of go on. And you had also, transsexual is actually not a term that it's kind of, we don't really use that anymore. Medically, it was used to distinguish between individuals who had surgical affirmation procedures and those who did not. Now, given the diversity of transition and that there's no one way to transition, we usually just say transgender.
Super. Would anyone else like to add to that from our guests?
I would say, this is Holly.
Sure.
I would say
sure,
when
Holly.
we think about LGBTQ+, Dane mentioned other identities like asexual or genderqueer or gender fluid. I think the plus is often added on to the end of LGBTQ to emphasize that it's an inclusive identity group. And really, the folks, if you identify in some way as yourself as a queer individual, what that means to you in regard to your sexuality or your gender expression, then LGBTQ+ is something that is meant to be inclusive of those identities for different folks. And because I just mentioned another term, gender expression. So gender identity is like who you identify yourself as. I like to think that's who you go to bed as. Like when you lie down your pillow at night, your gender identity is who you are as you lie down and fall asleep. Your sexuality is who you go to bed with. And that could be with someone who's similar to you or different, or maybe you don't go to bed with anybody. You're identified as asexual. But your sexuality is who you're going to bed with. Your gender expression is what you do outwardly. Do you paint your nails? Do you wear makeup? Do you wear a dress or a skirt? What sorts of expressive things do you do in your everyday life? And those can sometimes match the gender you were assigned at birth, and sometimes it might not match with what you were assigned at birth. Those general terms are kind of how we think about someone who's transgender, who identifies or expresses themselves differently than the gender they were assigned at birth.
Thank you, Holly, for that. And I want to stay with you, Holly, because you had mentioned early on that you are still a patient at Duke. And so could you tell us a little bit about your journey, if you don't mind, through gender transition and how that led you to, choose gender medicine, if you will, and some of your interests? If you can you do that?
Sure, yeah. I'm not shy about mentioning that I get my healthcare at Duke as a Duke employee and a Duke patient. I've had healthcare at different institutions, at Emory as well in Georgia. My PCP there was actually specialized in rural medicine and telemedicine, and she gave care to folks throughout the Southeast. I think gender medicine is something that very closely aligns with telemedicine and issues of access and disparities and who lives in metro Atlanta or who lives in rural South Georgia. These issues for me are issues of access and health disparity, and I've been passionate about that throughout my career as a medical learner, as a medical student, and today as a physician. My experience at Duke as a patient is Duke's a fantastic place. You've met some of these providers here who do excellent work at Duke Health. I think that I'm obviously biased, but I think that Duke is an incredible place for gender medicine and overall in North Carolina. My interests in gender medicine are mostly related to the research and application of public health disparity outcomes research. Clinically, my practice is as a general surgeon. So I work currently, I'm training to manage cancers, traumas, vascular disease, those types of things. So I'm not practicing in gender medicine at present, but it's something that I experience day by day. And it's something that I'm passionate about having a part of my research background.
Super. Dane, let me come back to you. I think you probably are practicing in gender medicine, aren't you, with some of your clinical psychology?
Absolutely, absolutely. And I've always been interested in gender, and particularly, kind of my research has been on kind of like the consequences that people face when they, when they kind of break the gender norms or go beyond the gender binary, and how society responds. So that's been a lot of my research. But clinically, it really is about a multidisciplinary team, at least at Duke. And so I get to do a lot of the fun part of when people come in and they're wanting to explore their identities and figure out what steps they'd like to take. And then I can help get them to the right place, to the right doctor, whether that's Dr. Kelley or Dr. Rizek is our plastic surgeon, and in the adult world. And basically what I try and look for is, when I'm usually the one who's responsible for making the diagnosis of gender dysphoria. And so I'm looking for ways that people avoid looking at themselves, so I've had some teenagers that have covered the entire bathroom mirror with shaving cream so that they did not have to see themselves when they got out of the shower, or who just don't take showers because the experience of looking at a body that doesn't match how you feel and experience yourself is really distressing. So those are the types of things that I work on and get to consult with a lot of other medical providers, OBGYN, well, and dermatology.
Super. Thanks, Dane. Dr. Kelley, I do want to come to you now because Dane had just mentioned his work with you in this team at Duke, and maybe you can talk a little bit about your work within gender medicine.
Sure, happy to. So I mentioned earlier that we started our adult clinic in 2018, but the pediatric group had already started their clinic, I think 2 or 3 years prior to that. And our patient population has grown tremendously since we started. I probably have over 200 patients on my panel now. I'm very interested in education as well, educating our residents and our fellows. And I saw that there was a great need in our division because we don't get a lot of training, or really there was not much training at all in endocrinology. And when there's a lack of training, then providers are really uncomfortable in prescribing hormone therapies. Even though we prescribe these hormones all the time and we're very familiar with these medications, but there weren't many providers in our division who were comfortable caring for transgender patients. And so, so it's been my goal to make sure that whoever graduates from our program has experience with this and comfort with it, because no matter what they go on to do, they're going to be seeing transgender, non-binary, LGBTQ patients, and they should need to be comfortable and know how to treat everyone with respect and feel comfortable. Especially if you're an endocrinologist, you should feel comfortable with the hormone therapies. It's been a very rewarding experience. I have definitely developed a team with Dane and our other colleagues across other departments at Duke. We're really trying to develop our program and improve access for our patients and improve the number of services that we provide, and make sure that the patient experiences are overall optimized. We also hope to contribute to research, so I am in the process of creating a registry of my patients. I would like to look specifically at hormone therapies and the short and long-term risks of hormone therapies. There's a lot that we still don't know, and we need a lot more research in this field. And then the other reason it's been really rewarding is because I'll have patients come to me who have been wanting to start hormone therapy for years, and there's been a number of barriers for whatever reason. Parents not supportive, not being able to find a provider in the area, not knowing where to go. And it is not uncommon for me to tell somebody at their first visit that we're going to start hormone therapy today, and they'll literally cry during the visit because they are just so thankful. So, I'm really proud to be a part of the team at Duke.
Super. Dr. Kahai, Dr. Kelley just mentioned, about pediatric patients, and I want to spend some time with you talking about what percentage of your practice might be devoted to gender medicine and how it's affected in your area of the state in Brunswick County. As you mentioned, you do a lot of rural and underserved work. Can you speak to that?
So I don't dedicate my practice to gender medicine as a lot of the specialists here do, because I'm a general pediatrician. But as part of my general practice, I ask patients who are starting to go through puberty, and then as they evolve through that process, about their gender identity and how they feel, about their sexuality, and then kind of transform or help create a pathway for them that we can proceed down, whether it's an affirmation or it's someone who's a little dysphoric, recommend them to a therapist or for hormone therapy or whatever may be appropriate. But it's a small percentage. What is really important to me is that I see we take care of about 250 foster care children with a primary medical home for them. And a lot of them are adolescents who've faced abuse and trauma. And it's really surprising to me how many of them have either gender dysphoria or gender identity issues. And I'd love to look at that, excuse me, in a research methodology to see. I don't know if that's the precipitating cause in a lot of them, whether that actually precipitated the home aggression or violence that caused them to leave home. It is in some of them, for sure. They've come out and told me that, and that's not unheard of at all. But so it's concerning in that particular population. I think that we get so caught up with a lot of the other social aspects and treating their behavior issues and perhaps not getting down to the bottom of what may be causing those issues. And I really feel like we have to address gender identity, sexuality, how comfortable they are talking to someone and why not. So that is a big issue. And just being in a rural, underserved area, we don't have any specialists. Holly, you were talking about Duke. I wish we could access Dane and Dr. Kelley, but we can, of course, we can always refer patients over, but it's not down the street or down the hall where I can say, hey, by the way, I've got so-and-so, and what do you recommend? Put our heads together. So, I take off a different hat and put on a different one, but all in all, I'm a general pediatrician, and we don't have those resources here. So in COVID times right now, we're using telemedicine. I haven't started doing well checks via telemedicine because I really like the one-on-one, especially with the adolescents and the pre-pubertal age group. So I keep that as a one-on-one, and we have dedicated times for well checks. So I still go through that with them. But I know that telemedicine is definitely something that we can use to access patients who cannot have adequate resources for transportation during this time. I hope that answered your question.
Oh, absolutely. Been a robust conversation so far. Thanks for everybody's input on that.
Could I add a comment there?
Sure, go ahead. Absolutely, Holly. Go ahead.
So Dr. Kahai mentioned something about the great prevalence of patients in her practice as a general pediatrician who may be encountering identity issues, sexuality issues, challenges at home. I think it's really important that these types of conversations that we're having it's great to be at Duke, but it's so much more important that these conversations happen in the general pediatrics world. It's because it's really doctors like her or PCPs or other providers out in the community that need to have these important conversations. I wrote a paper last year with someone from the NICU actually at Duke in general pediatrics mostly, looking at ways that GPs can use the HEADS assessment, right? So a tool we use to take social history for a pediatric patient, ways to think about asking every child across the board, whether they've had issues with drugs at school, violence at school, gender identity, sexuality. By incorporating that into every GP type visit, you can capture more children who may have an issue that may not be recognized. It's also really important to remember that nationwide, there's always challenges with LGBT youth. And it's important to remember that the data shows 40% of homeless youth identify as LGBT. And that is a statistic that varies from rural to urban areas. But I know when I lived in Atlanta, we had a big problem with homeless LGBT identifying youth who would end up in larger cities having been turned out from their homes. So I would just really applaud the work of Dr. Kahai in our community, but really encourage all of us, Dr. Kelley, Dr. Whicker, to identify ways for all of us in cities to also broaden our reach to other rural communities. That's really how we're going to make a big impact.
Super. As a follow-up, Holly, while I've got you, and I look for others to chime in on this, it seems to me as we've moved through time, and particularly now that we're having this discussion on the Power Hour, and Dane, as I mentioned to you, you guys were at Durham Orange. What do you think the prevalence of transgender individuals is in the general population now? And I know that's a difficult question, but give it your best shot.
Yeah, it's a difficult stat overall to pull out. I'll tell you that from the best research, the research that I've seen, I love to hear other people's stats. I hear that it's about 0.8% in the general population. But it's tricky because it depends on how you define it. Like I will identify as transgender and I'll check that box on any survey I take. But I have a friend who identifies as transgender, doesn't take hormones, hasn't had surgery. They identify as gender non-binary. They would fit in that category of transgender, but they may not necessarily be counted on the census, so to speak. So I think that the stats that I've seen for people who will raise their hand and say, yes, I identify as transgender, I think it's about 0.8% nationwide.
Dr. Kelley,
which I think is similar to the stats actually on Hashimoto thyroiditis, the last one I checked.
Interesting. Dr. Kelley, you had mentioned during your discussion of the last question that your patient population now in your clinic was up to about 200 patients in your panel, I think. So clearly you've got an upward, increasing curve. What do you think the prevalence is in the general population?
According to the Williams Institute out of the UCLA School of Law, the prevalence is about 1.4 million adults are transgender and 150,000 youth ages 13 to 17 are transgender. The prevalence is increasing amongst younger people.
Okay. And do you attribute that to folks like yourselves just probing and asking questions that weren't asked maybe 5 or 10 years ago, so now we're actually querying for that?
I suppose, yeah, I would say it's cultural differences, the increasing social media, and which allows. I would say a lot of my patients will say that they didn't know what it was, but then they searched the internet, and by looking on the internet, they realized, oh, that I didn't know that there was such thing as transgender. That fits me, and so I would imagine that's a contributor.
Right.
And
okay. Go ahead.
Oh, I was
Sorry,
just going to say there are definitely cohort effects. So like there's a big study out of University of Minnesota. It was like 85,000, 83,000 9th through 11th graders. And among that population, 3% identified as trans. So I think that and if you look at kind of, there are actually Gallup polls that will show you the trajectory of especially people in the millennial cohort is just, it's approaching 10% who identify as LGBTQ broadly, versus like 1.2 when we get down to kind of like, you know, I'm trying to think the greatest generation. I'm trying to think of the label of World War II.
The silver generation.
Silver generation, I like that.
Can I ask Dane to maybe help us understand that statistic you just quoted, you know, how you quoted the millennials, and split that? Is that an age difference that is responsible for that increase in number, that statistic?
It seems like there's actually a culture shift where gender and sexual orientation are really being talked about by youth. I don't know if you've experienced this as well. And there's just more of an openness and awareness. And they, you know, I had a 13-year-old come into my office and explain to me why he did not want to have a radial forearm phalloplasty with very accurate detail. It's like, so there's a lot of information for people, it does seem like there's just more openness and acceptance around people kind of being somewhere in the middle with their gender.
Super. Dr. Kahai, did you want to add anything?
No, I was just curious about his.
Okay. Dr. Anthony Fauci, who I think everybody in the United States probably has some knowledge of Dr. Fauci one way or another, says recently that when you're in the middle of a crisis, just like we are with the coronavirus now, it really does shine a bright light on some of the weaknesses in our society, particularly in public health. And then, you know, we want to get into a discussion now about how COVID-19 has disproportionately affected Black, Latinx patients, LGBTQ plus. And so considering all these health concerns, how has the COVID-19 pandemic affected gender-affirming healthcare patients? So I want to go around the panel, and I want to get you each to chime in on that. Dr. Kahai, let's start with you, please.
So just taking Dr. Fauci's comment, I really feel like I like to tune into that particular comment is I think that we have been forced to become very exquisitely sensitive to what the needs are in society today. So it's almost like we've taken away the periphery of unimportant stimuli or materialism that we have around us, because the bottom line is right now we're all forced to go back home. Most of us are isolated within our homes with our families, and it's not so much about my new iPad, or I'm going out for dinner, or I've got my new Gucci bag. It's more about, you know, mom's working with Tanner, helping him with his homework, because they have to. So I think that it's really forced us to come to terms with some of the common things that perhaps society had lost in general as a society, and we're touching base with those exquisite needs again, which are so essential to us being human beings, and sharing with each other. And having said that, there's no question that there's a huge discrepancy between the rates. Say, for example, the Latino population, they may make up a fraction of the North Carolina population, but their rates may be, I think it's 6 times or 8 times higher in terms of the COVID infections. So depending on what age group you're looking at. So they tend to have a 60% rate in the under 60 years of age patients versus the wide populations, which is in older population, 60 years and older, for example. So it's the younger generation that are getting infected. And I don't know that people have really broken down why we're seeing this race discrepancy. I think because it's how you look at the population statistics and the data and whether they're defined as cases. So there definitely is a huge discrepancy between the numbers. We see that in the African American. We'll definitely, I haven't actually honestly seen a report in the LGBTQ population where that's really made a difference, but I can imagine that it has in terms of them accessing care and going through gender affirmation surgeries or hormonal affirmation therapies. But we've definitely seen a difference in the rate of societal subpopulations and how they break out with COVID infections.
Super. Dr. Kelley, how about you?
Yes, so there are a lot of things that I have noticed with my patients in terms of access of care and exacerbation of mental health illness due to COVID. So transgender patients in general experience a lot more psychological distress than the general population, higher suicide rates. And I think we can all say that we've all been experiencing more stress and anxiety since this pandemic started. I see that not just in my gender clinic, but across my patient panels. But I'll have to say that it's particularly affected this particular patient population because of their already underlying higher levels of anxiety and stress. So that's been concerning to me. And then alongside that, the access to mental health services has become much more difficult. So I have a patient who can't get to appointments because they rely on public transportation, and obviously a lot of us would be concerned about using public transportation right now. On the flip side of that, we have found this whole new world of telehealth. And so in a way that has improved some access, and I've been using telehealth in my clinic. I was exclusively using telehealth probably until about May, when we shifted toward bringing in new patients to see new patients face-to-face, and then video visits for all of my established patients. And I would say that we are actually going to be studying this. We have a survey going out with the Sexual and Gender Minority Research Program at Duke, looking at the impact of COVID and telehealth on our LGBTQ patients. But overall, the feeling that I have gotten is that my patients really do appreciate telehealth, and it does allow us to improve access, and with patients being able to be very comfortable just sitting at home, going to their appointments. Some other issues have been just delays in being able to start on hormone therapy, or I'm sure Holly will talk about the delays in terms of accessing surgeries, but there are a lot of things that are required prior to surgery, such as smoking cessation, weight reduction, and those are all services that have been harder to access due to the pandemic. Also getting letters. So again, that goes back to trying to be able to get your appointments with your therapist in order to get letters for surgery. As far as hormones are concerned, there's not just physical changes that occur from hormones, but there's a lot of mental and emotional changes. And so if somebody comes to me and they're already kind of not in a very good place mentally and emotionally, and don't have that support and don't have that connection with a therapist who might be helping them through this transition, then it might not be a good time to be starting hormone therapy. Some hormones can, such as progesterone, can cause worsening of depression. So I have one patient that I can think of right now who is actually an elderly transgender woman who is on Medicaid in Virginia and has The telehealth has been great, but trying to access other services, including counseling, has been difficult because she can't necessarily just come to Duke very easily. And she's very, very depressed and very lonely, but she wants to start progesterone. But I'm concerned about starting progesterone because it can actually worsen depression. And she doesn't have that connection. Should that happen, she's alone and doesn't have that support system. So those are some of the things that I've experienced. So just kind of in summary, I think the telehealth has been an improvement, and I foresee that we're going to be using a lot more telehealth in the future to reach more patients, like our rural patients. But on the flip side, the worsening of the psychological distress and the inherent barriers such as finances and lack of transportation and housing, just kind of making things worse for these particular patients.
Dane, Dr. Kelley mentioned so many instances about mental health and higher suicide rate. And so I think I want to come to you next on this question and let you chime in on a lot of that stuff.
Yes, and Dr. Kelley is very right about there is a huge backlog of services, and we've seen a tremendous uptick in need since COVID happened. And I really think that a lot of that is due to isolation that people are experiencing, and they're not able to connect with their communities. And then also the financial economic stressors are all things that I hear across the board. I think that, when you think about a gender specialist mental health provider, that can make things even more difficult to find one who's trained to kind of write the letters that you would need to write to get the insurance company to approve a surgical procedure. And so I've also seen a backlog in, trying to get people into surgery, depending on the type of surgery. Sometimes with a hysterectomy, those have gone through, but anything having to do with plastics was pretty much frozen during COVID. And then the other thing that I'll mention, the suicide rates are already. They just released a report on youth that was terrifying. It was a big bump. 60% of trans youth had considered attempting suicide, and within the past year, and I think it was 50% of the LGBTQ community, and so typically those numbers have been, and at least in North Carolina, it's about 42% is the lifetime suicide attempt rate, and for transgender people. For the general population, it's only 1.6. So you can, we already have a huge discrepancy with risk of suicide with our trans patients. So yeah, I think that's a big part of it.
Yeah, thank you. And finally, Holly, I want to get you to chime in on this subject, particularly where it relates to your surgeries.
Yeah, so I just want to really validate and affirm the things Dr. Whicker and Dr. Kelley said there. It really resonates with me because I have a lot of friends in the community who are experiencing exactly what they just described, older folks, younger folks, and it really kind of paints a picture, a grim picture of the public health crisis for so many people around the country. Around March 30th of this year, Duke surgery really shut down significantly, with a lot of our cases really being curtailed. And over time, we've shifted to kind of a triaging-based system, like finding which surgeries are urgent or emergent. And, during my training as a surgeon, I was still involved in a great number of emergency surgeries. One of the things about gender surgery and general surgery is that it really depends on who you ask if a surgery is elective or life-saving. I've done some work up in New York City with Dr. Jeff Ting, who's like a very renowned gender surgeon there. And if you ask him, in his opinion, gender surgeries are life-saving surgeries. They reduce the suicide rate. They make a huge impact in patients' lives. A hysterectomy can be an incredibly affirming surgery for a transgender man. But when it comes down to how we define surgeries as elective or urgent or non-emergent, that's been an ongoing discussion with Duke Surgery as a community, because we don't want to put our nursing staff, our patients, our communities at risk, but we want to find ways to kind of reopen safely. And I've been glad to see that at Duke, I would say around like May or June, we started performing gender affirming surgeries again. And I've been glad to see that. Obviously we're, wearing masks, we're using COVID testing, we're being very smart about things, but it's been a real change in how we approach surgery for every single patient within Duke.
That's interesting. So Holly, you guys are back at full capacity in terms of your surgical schedules, in terms of
I'm not sure I'd say at like full capacity. We're certainly doing more volume as a department of surgery. We're doing much more today in August than we were in April. We're certainly doing more now. Are we the same as August of 2019? I'm not sure yet. I haven't seen that data, but I think that we're getting better and we're getting safer and we're getting more experience like everyone else is in managing things from a risk management perspective.
Sure, that's super. I want to talk a little bit more, Dr. Kahai, about pediatric and adolescent patients. Is there that timeline that happens? And can you talk a little bit about how, from a clinician standpoint, you talk to your patients, you counsel your patients in terms of when they might want to go through a transition, before puberty, after puberty? And I want to get Carly to also get involved in this discussion as well, because the hormones are going to be important. But Dr. Kahai, can you talk about that first?
I can talk about it. I can tell you that I don't usually make that recommendation. I usually leave it to the endocrinologist or someone like Dr. Kelley, who's much more experienced than I am.
Sure.
That's just something that's beyond the average pediatrician. But I will tell you that we tend to look at it in a couple of different ways. So the onset of puberty is very difficult for a lot of trans folk because it starts validating a lot of the secondary sexual characteristics that they don't want to see. And so it becomes a difficult process. So even before, just as puberty just starts onsetting around 10 or 2 or around the peripubertal phase, a lot of endocrinologists feel that we should perhaps start suppression of puberty at that time so they don't develop their secondary sexual characteristics. And then endocrinologists usually recommend that we probably wait until about 16 until we go to hormone suppression therapy. So there is a timeline definitely that they tend to follow. It used to be recommended that we wait till 16 years of age, but I think a lot of clinicians now are starting not to wait for that 5 to 7 year gap between when they first started with suppression of the puberty versus just using hormone affirmation therapy. So it really depends on the clinician. I don't know that they're going by those hard guidelines anymore. And I'm sure Dr. Kelley can fill us in with that a little bit more. But so why they select the timings are really important from a hormonal perspective, and it's a complex process. So I'll let Dr. Kelley explain a little bit more.
Dr. Kelley? Go ahead.
Hormone therapy in adults, but actually Dr. Atkins is on this call, and she's the director of our Child and Adolescent Gender Clinic, and she might have some other thoughts on the kids.
Yeah, I think Dr. Kahai's accurate in what she was saying is, you know, if our patients are feeling uncomfortable with their gender identity when they first enter Tanner 2 puberty, then we would potentially pause their puberty to give them time to explore that identity and decide what direction that leads them. And then we are shortening the time interval now more and more at which we would put them on gender affirming hormones. As we get more and more data, there's more data now down to 14 years of age for starting gender affirming hormones, and I routinely feel comfortable with starting patients in that age range. And for some of my patients who have significant dysphoria or who started puberty blockers at what would be the maybe 8 or 9 years old for someone who is assigned female at birth, I don't want to leave them without any sex steroids in their body for years and years and years. And I want to try and get them into puberty with their peers. And so I may start them, you know, at 13 or so, as we're learning more and more about how well these work and how to avoid things like potential osteoporosis and other consequences of the lack of steroids for a long term.
Gotcha.
Thank you.
Thank you.
Really brought up an important point about, I think if you suppress endogenous puberty and you don't intervene until the traditional guidelines of 16 or so, then you have a child or a patient who's 11 or 12 years old in high school or starting college, and they're just starting to go through puberty, that phase. So I think it's hard enough to go through that for a patient who's not LGBTQ, but then to be going through that with all those hormonal phases at that time, I think is particularly difficult. So I think to initiate puberty at that time is much more challenging.
Okay. I want to just get one other question out to Dr. Kelley. When you compare pediatric patients, adolescents versus adults, and you're going through the hormone therapy, what are the big differences there between those two sets of patients?
Well, so I only care for people who are ages 18 and up.
Okay.
Might not be that big of a difference between caring for an 18 to 20-year-old and you know, a 15 or 16-year-old. I definitely approach that a little differently. I might see more patients might come with their parents, and there's a lot more parental involvement as opposed to somebody who's a little bit older. I mean, I'll see, you know, my oldest patient is 79, so definitely is approached very differently. And I would say that most of my patients who come to me have really thought about it for a long time and researched and figured out that they know they want hormone therapy. They're not questioning it anymore. And many of them will have already seen a therapist for a period of time. And they're ready to start. And like I said earlier, oftentimes I'll start hormone therapy for patients at the first visit. I might aim for possibly lower levels in younger patients. And I have noticed from the pediatric patients who have transitioned to me that they are on lesser levels of hormone therapy, particularly testosterone, and target maybe lower testosterone levels than I might for adults. So we might start kind of increasing that hormone therapy and while monitoring to make sure it's safe. But I don't require any kind of mental health letter prior to starting hormone therapy unless I'm concerned that somebody has some kind of severe depression that's uncontrolled and they're not getting treatment for it. Or if there's some other comorbid condition that makes me concerned, such as autism, that I want evaluated prior to starting.
Right. Dane, I want to come back to you and kind of get your take on the same question. Adolescents, pediatric patients, versus adult patients in your practice?
Yeah,
Big differences.
absolutely.
What are the differences?
Yeah, so those differences are, I think the biggest one is the presence of parents, as Dr. Kelley alluded to. So with the kids, I'm also talking to the parents a lot, and there's a sense of urgency because really, can't remember if Dr. Adkins mentioned this or not, but it's really Tanner stages 2 and 3 that you really want to start that puberty suppression. So there's a narrow window when we can actually suppress puberty, and that's intended to be done in tandem with therapy. So then I can work with the patient. I have workbooks that we go through to figure out if they want to start on hormone replacement therapy. With adults, depending on if it's someone who's coming in to get a referral to Dr. Kelley or, plastic surgeon, they already know what they want. Those are usually like one time, a few times, not just one, usually a few sessions it takes to get all the information. But if they're comorbid health problems, and those are also like psychosis that's untreated, dissociative disorders are really common. And so we have substance use, but really I want to make sure that they have the capacity to make informed consent before they start some sort of irreversible or partially irreversible treatment.
May I just interject a second? I think
Please.
Dr. Kelley brought up a really important point when she said that we don't need a psychological or a psychiatric evaluation before we start hormone therapy, because and with all due respect to Dane, this used to be something that was required in the past and mandated by insurance companies, and I think it's wonderful that we moved away from that and given more control and validation back to the patient and the person who's actually seeking this therapy, more so than having to prove that they have a certain gender dysphoria or actual disorder that needs therapy.
Super. We're approaching the top of the hour, and so I've got a couple of questions that probably will be answered very in short term. As you know, you probably know this, as of July of this year, North Carolina has no law protecting LGBTQ plus individuals from discrimination in private insurance. What I'd like to know from you all, if you experienced any of that with any of your patients. Dane?
I have not, no.
Okay. Dr. Kelley?
I don't have any experience with it.
No feedback on that? Dr. Kahai?
I did. I had a 15-year-old boy who actually got put into foster care because his parents became so abusive when he started to talk about his gender identity issues. And that was actually the best thing for him, because they actually moved to San Francisco and enrolled him there in the UCSF Transgender Institute and University. But so really that happened because A, the parents refused to acknowledge his gender identity issues, and B, because Medicaid, our insurance, wouldn't pay, consider that elective surgery, so it wouldn't pay.
Okay. Okay, guys, this has been a great discussion, but I want each one of you to take just a moment, because we only have a couple of moments left, and think about the last year, and a lot of that's been COVID. And is there any last bit of advice, things that you've learned, nuggets that you would like to impart to our audience today? And so, Holly, I want to start with you, please.
I would just remind everyone to be patient with our patients and recognize that whether you look like you have health discrimination issues or not, this has been impacting so many people. And folks in rural communities, folks of color, folks of difference are all really disproportionately affected. So I would encourage all of us to reach out and create whatever community we can to help our own communities, wherever they may be.
Dr. Kelley?
I would just like to encourage everyone to make sure that your clinic is a gender-affirming environment from the time a patient talks to somebody on the phone to when they walk in the building to the appointment to when they leave. Misgendering is very prevalent, and we just need more training of all of our staff.
Franklin, I'd like to throw this right back at you, because I would love for the State Medical Society to look at the policies we have in place, how they protect our patients. Is there something we can do better? Do we revise our policy if we do have one? Could we not have a CME at our annual meeting to address this issue that's crucially important for our patients and to improve the education of physicians overall?
I think that's a great suggestion. Thank you. And finally, Dane.
Yeah, so I guess I would piggyback a little bit off of Dr. Kahai. I agree with everything that's been said. I think telehealth's really opened this up, but I also think, in an academic medical center, if you're thinking about promotions or raises in whatever kind of like clinical setting you may be in, including something about, what are your contributions to being more inclusive and learning more about treating marginalized groups of people is just so important. So maybe thinking about ways to do that.
I want to thank the guests today. You guys have been fantastic in a very interesting subject that we got to talk today about. And so with that, I want to hand it back to Danielle. Danielle?
Yes, I echo those sentiments absolutely. Thank you guys so much for a really great discussion and some wonderful information. This concludes our Power Hour for today. Again, want to thank all of our guests for taking time to be with us today, and all of you that have joined in for this important discussion. Our next session will be August 21st, and we'll continue the conversation around racism bias and the focus of the conversation on collaboration and community. So happy Friday, everyone, and we look forward to seeing you at our next Power Hour. Thank you all.